Hello, and welcome to another episode of the AUA University Podcast. I'm your host, Dr. Mark Gonzalgo, Professor of Urology at the University of Miami and Chair of the AUA Office of Education. Today, we're tackling one of the most challenging, complex, and let's be honest, sometimes frustrating areas of urology, male chronic pelvic pain. It's a condition that walks into every urologist's clinic, yet we all know it's rarely straightforward. The patients had multiple rounds of antibiotics, a handful of CTs, maybe even prior procedures, and they're still in pain. The great news is that the new AUA guideline on male chronic pelvic pain finally gives us a roadmap, clear definitions, diagnostic steps, and evidence-based management strategies. And we've got two of the people behind it here to help unpack what it means for everyday practice. It's my pleasure to welcome Dr. Elise, Professor of Urology, Obstetrics and Gynecology and Neurology, and Medical Director of Multidisciplinary Pelvic Health at Albany Medical College. She is chair of the Pelvic Pain Committee of the International Continence Society and co-authored this year's AUA update on pelvic pain in women and the AUA guideline on male chronic pelvic pain. We also have with us Dr. Dane Johnson, assistant professor at Washington University in St. Louis, where he specializes in andrology, infertility, and sexual health. Dr. Dane, Dr. Johnson, welcome to the podcast.
Thank you.
Thank you for having us.
So let's start with the big picture. Can you tell us about the new AUA guideline on male chronic pelvic pain? What makes it unique? What's new about this guideline? And why was it needed?
Well, Dr. Johnson and I both were co-authors on the guideline. And I think, for us, we still are seeing it from a very different view, right? It's a pretty complex diagnosis, chronic pelvic pain. Wouldn't you say, Dane?
Absolutely. Many different avenues lead up to our clinic from many different places, including symptom-wise. Hence why there's kind of a whole gamut described in the guidelines.
Mm-hmm. It's a pretty overwhelming guideline as well, wouldn't you say?
Very robust.
Yes.
So the document was constructed, I suppose, into three major categories. I think if you're trying to cover some of this, at least at a high level with clinicians, can you walk us through at least a portion of this and some of the most important or salient points?
Yes. Well, I think one of the really unique things about this guideline is that the authorship was multidisciplinary. So it was not just urologists who wrote it. We had a neurology pain management specialist, physical medicine rehabilitation physician. We had a physical therapist, a doctor of physical therapy, who really guided us on the pelvic floor myalgia. So there was a lot of interdisciplinary communication regarding the sections, but so the first section is chronic pelvic pain syndrome or chronic prostatitis, chronic scrotal content pain, and then pelvic floor myalgia is more the musculoskeletal side of chronic pelvic pain in men. But for all of the sections, one of the main points is that these syndromes are diagnoses of exclusion. That means that we have looked at Table 4 and contemplated or ruled out confusable disorders based on the patient's story.
Great. And any follow-up to some of the segments, for example, with whether it's CPPS or chronic prostatitis, chronic pelvic pain syndrome, as you pointed out, scrotal content pain, or pelvic floor myalgia. Could you maybe highlight one or two key components of each of those?
Sure. I'm going to leave the chronic scrotal content pain to Dane because it's really his area of expertise. But Figure 2, the diagnosis of male chronic pelvic pain conditions, is a really nice sort of like overall approach to chronic pelvic pain. And again, it emphasizes ruling out those confusable conditions. Emphasizes a history, a physical exam, making sure the patient doesn't have an elevated post-void residual, making sure they don't have an infection. And then chronic pelvic pain syndrome features perineal pain. The scrotal pain can be bilateral. You can have penile pain, dysuria, ejaculatory pain in those syndromes. Then, of course, it references the guideline on male IC or bladder pain syndrome. So that would be bladder pain, pressure discomfort, relieved by voiding, associated with LUTS. And pelvic floor myalgia, you would be likely to find tender pelvic floor muscles on exam, and the guideline brings you through how to examine those muscles. Dale, would you like to talk about chronic scrotal content pain?
Yeah, and just to emphasize, one thing we've mentioned already is the guidelines are really used for this kind of nebulous area of diagnosis of exclusion. And so many of the patients that end up in our clinic, they're not going to fall into one strict category. There are many patients that have multiple syndromes of pain, whether it's chronic scrotal pain or chronic pelvic pain, or a combination of both. And so the guidelines that we've developed are very, very helpful for just kind of finding what symptoms line up for that patient's complaint and kind of following what the data says, how to best help those patients. And so while my area of expertise certainly kind of hones in on the testicular and scrotal content area of things, so many of my patients come in with a multiple pain complaints, a regional syndrome, if you will, and oftentimes a really big point at the end of all these conversations is most often it's going to be kind of a multimodal approach to these various pain syndromes. And so sometimes those patients kind of head down the route of some intervention, but ultimately the best outcome may be kind of taking two or three of the approaches from the guidelines to apply that to that patient specific pain complaints. So for the chronic scrotal pain, or the chronic scrotal content pain, it's kind of a mouthful of words. It's really just describing things in the scrotum, whether it's testicle, epididymis, spermatic cord, etc. Sources and locations of pain. So I hope to take some time later to just kind of go over some of the more, I think, more straightforward diagnoses that can cause chronic scrotal content pain, and use that to kind of highlight how this guidelines kind of really illustrate what to do about patients that don't fall into any of those kind of stereotypical presentations of varicocele or epididymal spermatocele pain, to really highlight how the guidelines can kind of help for those patients that, again, fall into this diagnosis of exclusion kind of criteria.
Right. And, as you mentioned, there are a lot of figures and pathways, management pathways associated with the guideline. We'll be supplying the links of those in the description of the podcast for our listeners. And, what you mentioned, particularly with treatment of some of these syndromes, which is key, is, we often see patients who've been treated empirically without a full workup. And, I think it's important to identify treatable causes early and avoid unnecessary antibiotics or procedures if at all possible. So let's talk diagnosis. A man walks into your clinic with persistent perineal or testicular pain. Where do you start? What are the critical elements of evaluating a man with chronic pelvic or scrotal pain?
Dane, I start with the history on these patients. Why don't you tell us about your approach?
Yeah, certainly. Ultimately, these patients come on your schedule and have that diagnosis next to the name, and that probably makes a lot of physicians pause before they step into the room. And I think one of the key parts of our conversation should be, every time you step into that room, kind of start with a fresh story. You can look up patients' indications and histories, and ultimately the story that they described may be quite separate from those that have come before them or come after them. So I think the critical component to working with these patients is having a very good history and a very good ear, listening to the symptoms, and you're doing a little bit of detective work trying to use the signs of essentially their presenting symptoms to point to an eventual diagnosis. So unfortunately, as I tell patients many times in my office, I don't have a pain scan. I can't provide a test that can help us pinpoint to a specific, specificity, this is what's causing their pain. So instead, we start with the very detailed history that includes both urological and sexual and physical histories for any signs or tips that might point us in the direction of a final diagnosis.
So what if a patient came into you and said, on March 13th, I had sudden onset left testicular pain with, bladder irritation and a little pain in my left back.
I'll start with a time frame and try and have them specify exactly what symptom came first. Is this something that correlates to an activity that they were doing at the time as well? Was there is a physical exertion that may have caused a stimulus that started a regional pain in that region? You know, such as a hole in the groin or Any correlated symptoms beyond the pain, like nausea or vomiting, that could suggest other diagnoses in the area? Is there regional pain that are separate or independent from that specific testicular or groin pain? So I start with kind of the time-based analysis of saying, what did our symptoms start with? And then what seemed to evolve from there? I
Mhm.
think that that's kind of a nice way for the patient to present in their own words what they think's going on as well.
And I think most urologists, if they really hear what the patient says, can figure out if they had an acute UVJ stone or an acute hernia or some etiology that's related to the history the patient presents if they hear it.
Right, absolutely.
I think one of the things that goes along with what you had said earlier about the importance of the physical examination, things including that we forget posture, gait, hip, back alignment, because a lot of folks who I think talk about saying or carrying a diagnosis of a prostatitis actually end up being something else, whether it's musculoskeletal or neuropathic. So, in many ways, we're not just looking at the prostate. We're so focused on that. You need to look at the whole person.
Mm-hmm. Yeah, I mean, if your patient has an abnormal gait when they walk into the clinic or walk out, that's that may be something no one else has addressed. In the older patients, if they're coming in on a walker, why are they on a walker? Does anyone know they're on a walker, or is that a new thing? And uh, very often patients with refractory chronic pelvic pain, in 70% of cases, if they have also some sort of neurological clue, like an abnormal gait, abnormal urodynamic testing, pain that's radiating from the back all the way down the leg, including the pelvic area, then 70% of the time you're going to find an objective neurological diagnosis. So, for example, we've found multiple sclerosis in our patients, herniated discs, Tarlov cyst. And then, Dane, do you have a lot of those patients who come in with chronic overlapping pain syndromes or multiple autonomic symptoms like ringing in the ears in association with their pelvic pain?
I would have to say probably
Mhm.
is the answer there. Um, I certainly kind of ask if there's been any other similar recent changes that may not necessarily be pain, that could be neurological in source. That would be kind of like the opening statement to say, hey, tell me about anything else that comes to mind for changes that concern you. I think that that's kind of a nice opening for letting people kind of present their concerns.
Mhm.
Yeah,
Yeah.
it's important to, you emphasize, it's important to first hear the story, fresh from the patient, right? Pain, location, timing, relationship avoiding, ejaculation, bowel habits, even the psychosocial content. We talk about perhaps a focused physical exam. Could you comment perhaps on the salient points of what you do for our listeners when it comes to evaluation of a patient with this potential condition?
Dane, why don't you go first?
Perfect. Yeah. So let's just give a scenario where somebody with that history of groin and maybe perineal pain that radiates into the testicle. I think it kind of covers all the avenues there. And so, we had just mentioned kind of the overall objective view of the patient. How's the posture? How's the gait? Is there any neurological deficits that are obvious? When it comes to the focused portion of the exam, some of the things that I immediately evaluate would be palpate the anterior pelvis, the anterior portion of the inguinal ring, and pubic bone. Pubalgia is something that I can often trigger just based on a very gentle exam. Feel for an inguinal hernia. That's a very clear and obvious thing to check for most patients. And as well as palpating the perineum a bit. And so usually when there's a laterality to the pain, I will be palpating kind of the posterior scrotum, not yet going to a prostate exam, but posterior scrotum. Many times in that region, people have trouble really kind of focally pointing to where the pain comes from. They kind of point to that space, and it could be the side of the penis, it could be the spermatic cord, or it could be the perineum. And so I'm specifically asking questions like, does it hurt more when I push here or there? And specifically targeting things like the perineal floor, the spermatic cord, the side of the penis, and also the adductors of the leg and groin. That helps me kind of focally isolate pelvic floor complaint versus scrotal content pain. And if patients come in with that testicular pain or scrotal content pain, I'll be evaluating the testicle and epididymis and spermatic cord. Some patients come in with spermatic cord tenderness and not testicular tenderness. That kind of points to a potential diagnosis in one direction or another. Feeling for any congestion or induration of those structures as well can point to inflammation and could help rule out maybe an acute infection. Those patients present very differently, but sometimes you can find one or two infectious causes of chronic pain, unfortunately, as well. So it's one of the things that I pay attention to is kind of not just patient's reaction to my examination, but actually palpating the tissue and evaluating the subjective feeling of the tissue during the exam.
Dane, I'm curious, when you have a patient who has pain that's felt in the spermatic cord or the testis or the scrotum,
Mhm.
and you examine them and it's not tender, do you think that's neurological?
It does tip my opinion a little bit in that situation. Now, is it because they've had kind of I guess episodic inflammatory pain that's just not currently present during the exam? They often describe pain that might be intermittent in that situation. Whereas the chronic neuralgia, neuropathy type pain is going to be more of a persistent pain. And so if they come to my office that moment and they say, yeah, I've been having pain today, and then I do an exam and it's really benign, that would to me suggest a neuralgia in that type of scenario.
And how often are you seeing pain from like a port site or an incision that's just not been appreciated as ilioinguinal nerve injury?
That's not very common, to be honest. Not from what I've come across. I mean, it's certainly, now that you mentioned, I may keep that in the back of my head there. Um, the only patients I can think of that might come to me there would be from like an inguinal hernia repair,
Mhm.
which unfortunately is pretty scarred and a pretty obvious history from that patient. Um, or somebody who, for instance, has had maybe like a partial or a radical nephrectomy, um, but generally, those port sites might be in a much different location. So I haven't thought of a local nerve injury in that situation.
Yeah, I feel like in that case, the patient usually identifies, well, the day I had my surgery is the day my pain started, and then
Yeah.
they kind of give you the diagnosis.
Right. Yeah.
It's
Um,
interesting. You mentioned obviously that this oftentimes is a diagnosis of exclusion. And so, take the situation where now we've ruled out infection, we've ruled out structural issues, malignancy. Now what? Once you made that diagnosis, where do we start with management and how do you begin to structure your treatment plan?
Mhm.
before we move on, let me mention one last part. So I mentioned the anterior exam. Patients who complain of have more of a pelvic pain, perineal pain, pain with urination or bowel movement or ejaculation or all three, I do offer to do a digital rectal exam as well, just to kind of see if that prostate palpation might trigger that pelvic pain. Again, kind of thinking along the lines of prostatitis and chronic pelvic pain, uh, as well as taking the time during the exam to say, hey, I'm going to move my hand. I'm not going to tell them how I'm moving my hand, but I'm going to move my hand to the left, to the right, anterior, and posterior, and ask specifically again, trying to localize a discomfort or a tenderness on that exam that might again help us direct treatment down the road. So I'd remiss if I didn't mention the posterior exam of the pelvis there too. That's an important part for my exam.
Are you when we were doing the guidelines and we came up with figure 3A and 3B, looking at the levator muscles, was this something that was sort of inherent in what you do, or was this an education for you?
I would say specific. Uh, I would say specific compartments as helping me probably wasn't something I thought of beyond just trying to. Honestly, when I do that part of the exam, I think it helps the patient a little bit too. But when I do trigger a tenderness during that exam, it does help kind of say, hey, it hurt only on the right side where you're having pain, and on the left side it didn't. And they accept that diagnosis of maybe a pelvic floor myalgia type
Mhm.
scenario. So I definitely think that has helped me even be more specific when I tell the patient, hey, this is that compartment of the pelvic floor. I also think it just has really helped to just have put in your mind, this is part of that exam. as a roadmap to say this is an important part to do.
Yeah, I feel like when you can show a patient which muscle is hurting them and if it reproduces their pain, then they're really happy to go to pelvic floor physical therapy and address it. I mean, they're really happy to do anything that's going to help for the most part. Do you find that like hamstring injuries attaching to the perineal area is a common cause of pain or muscular attachments? Do you have to involve PM&R frequently?
I have not come across a specific muscle injury that might be, skeletal in source, whether it's exertional or not. Um, probably the most common one that I will get involved from our friends in the rehab side of things, it's actually more of of hip pain. So patients who come in with kind of a regional pain, they have pain in the testicle, it radiates up into the groin, but they also say it also radiates kind of deeper into the hip a bit. That's actually where I often come across this scenario versus more, lower extremity musculature.
Mm-hmm. And if the patient has pain with end range motion of the hips, especially if it reproduces the pain they're reporting, that's a really good clue.
Right. Yeah.
Great. Wanted to move on again to focus on treatment. I think these are all great points. Once the diagnosis is made, how do you begin to structure your treatment for patients?
Mark, I think that is really, again, the treatment for chronic pelvic pain has to do with the etiology, right? So treatment when you've found the cause, for example, if a patient has a Tarlov cyst that is causing pain in the S2-3 distribution, radiating down the leg, there's some conservative managements for that and also a surgical management for Tarlov cyst, dural wrapping techniques, for example. But if you're addressing a patient who has a syndrome, chronic pelvic pain syndrome, in the guidelines, there's very good evidence-based description of what you use. So table 6, for example, goes through the evidence in chronic pelvic pain syndrome, chronic prostatitis, the benefit of lifestyle modifications, alpha blockers, analgesics, neuropathic pain medications, acupuncture, for example. And for me, this is an education, Dane. What do you think as we went through the
Yeah.
evidence?
I think a big takeaway from this for me, and what I think for others will be using the symptoms of the syndrome to help guide the treatment. So a patient who complains of bladder pain or lower urinary tract symptoms plus bladder pain, we can offer pretty effective therapies, whether they're pharmacological or behavioral therapies or physical therapy. Tailoring the treatment based on the specific complaints of that syndrome, I think is a better approach than trying to say what the diagnosis is and what all should we throw at that diagnosis. So very effective things for bladder pain can be things as simple as alpha blockers or even the phosphodiesterase 5 inhibitors like tadalafil, which has been helpful in the younger men who don't really like hearing about the sexual side effects from something like Flomax. Same kind of in the same area as the chronic scrotal pain scenarios, which is again the symptoms that we're trying to address. Is this patient's presentation consistent with suggestive of neuralgia and neuropathic pain? In which case, gabapentinoids or tricyclic antidepressants can be helpful for kind of down regulating that pain signal coming from a chronic pain trigger.
Mm-hmm. And multimodal. So, as you have a patient who's making their way through these options, giving them a TENS unit to put over their tibial nerve that feeds back to the lumbosacral nerves, gives them just like something they can do at home. And, that in addition to physical therapy and your medications, for example. I also like to tailor the diagnostics to, what clues you have from the history. So if a patient has LUTS and bladder pain with filling and he's a 60-year-old man, it's really important not to turn off your mind to the fact that they may have bladder outlet obstruction, especially if they have pain with voiding, suprapubic pain with voiding, right? So for urodynamics in a pain patient, I really like to be in the room and see if the filling and voiding really reproduces their symptoms. and of course to rule out obstruction in these patients. You wouldn't do surgery for a prostate just for pain, but you certainly shouldn't shy away from relieving bladder outlet obstruction in a patient with bladder pain associated with voiding.
Yeah, it's important that you highlight the potential importance of multimodal care, right? Whether it's medication, physical therapy, and maybe a targeted procedure, it's all part of the bigger plan. Can each of you comment on perhaps some of the? I know it's a broad question, but pick, for example, chronic scrotal content pain or one of the syndromes, and comment on a targeted procedure depending on a symptom that a patient might present with.
Yeah, sure. Well, we can start with the chronic scrotal content pain. I think for the purpose of this conversation, it's helpful to kind of quickly go over some of the definitive diagnoses that may not have been covered by the guidelines specifically, because we kind of wanted to keep along these kind of guidelines of things that haven't yet been talked about. For instance, we didn't discuss varicocele in the guidelines because there's a pretty clear indication for interventions for varicocele. There's guidelines on male infertility and an overall acceptance that varicoceles, when symptomatic, can cause scrotal pain that is reproducible. It's going to be behavioral dependent, so things that cause exertional strain on the pelvic floor and the abdominal wall can elevate or exacerbate scrotum pain symptoms, and laying supine and resting can seem to reset. So patients describe kind of a wave of pain that builds throughout the day, and by the next day it resets. So I'm going to describe a few of those chronic scrotal pain that are essentially diagnosed, and we can say, here's that treatment. And then I'll pivot from that to say, here's what we do when we don't have those. Okay, so varicocele surgery is something that's routinely offered at most major medical centers, typically performed by somebody like myself, an andrologist and infertility specialist. The patient presents with 3+ month history of recurrent testicle pain that radiates up into the groin. It's associated with activities, longer time on your feet, rest overnight seems to reset. And I can actually kind of make that diagnosis based on a physical exam and a history, and ultimately offer what I do as a subinguinal microscopic varicocelectomy. Those patients do very well with low complication rates and generally very high success rates. If that patient presents with scrotal pain, and instead of having a varicocele on exam, which is the gold standard for diagnosing a varicocele, instead of that, they have kind of an isolated scrotum pain to the spot on the epididymis that represents, let's say, a 1 or 2 centimeter spermatocele. Those patients have pain localized to that spot, unassociated with activity. It may always hurt. It may come and go. It may be painful with ejaculation. They may have a history of a vasectomy. And in those patients that have a clear indication, I may offer an epididymectomy, remove the spermatocele plus its epididymis to reduce the recurrence rate. And those are pretty well accepted. We don't need guidelines on those types of presentations. Similarly, for a sperm granuloma, that would be higher up on the spermatic cord. It's an isolated lesion that's tender to palpation, painful with ejaculation. So there's several things that can be diagnosed on exam. An ultrasound can be helpful to rule out things like acute torsion would be something that would be in a much different category, but epididymitis or orchitis, which is less common in this, again, cohort of patients. I often get an ultrasound if I need to rule out those things, but my physical exam is really sufficient to diagnose the things that cause chronic scrotal pain. So if I haven't found those things, and we've kind of gone down the route of this person's received antibiotics, which is very, very common in my clinic, I won't be offering multiple rounds of antibiotics. And I think that's a pretty well agreed upon guideline here in our guidelines, which is you can consider giving an antibiotic to a patient who has never received an antibiotic before. In the rare situation that this patient may have a chronic epididymitis or orchitis, it's probably safe to give once. Again, in my exam, on my experience, those patients do present with a bit more induration and inflammation. So it's a different type of patient. Okay, so we don't have an infection. We don't have varicocele. We don't have a spermatocele, no sperm granuloma. This is the idiopathic orcalgia. This is the unexplained testicular pain. A key part of that workup is getting a patient history, something that suggests maybe an injury or trauma or prior surgery. Vasectomy is a common pre-diagnosed, prior to diagnosis comorbidity. The next key step in that workup, again, we're working through this diagnosis of exclusion, and so far we haven't had an anatomical or pathological cause for that pain. We do a spermatic cord injection, a spermatic cord block. And so we're going to inject an anesthetic into the perivasal tissue. I prefer to use a combination of bupivacaine and lidocaine for both the short acting and the longer acting. And the purpose there is to essentially perform a test. Can we turn off the testicle pain with a nerve block? And that's going to be essentially assessing for a local neuralgia, a gonadal neuralgia. This is important because patients with regional pain syndromes, if they're having pain from an extrascrotal source, whether that be neurogenic or neuropathic, or a regional inflammatory condition, those patients really won't feel much better from the spermatic cord. They would block. They would essentially have a failed benefit from that spermatic cord. So the patient that comes in the clinic responds to a spermatic cord block will describe at least a 50% reduction in their pain for at least 2 to 4 hours, preferably longer to 4 to 6 hours, depending on which your mixture of analgesia that you use. And that then indicates to me that with a otherwise normal anatomy, with no pathology to explain, with a nerve block that essentially silences or dramatically improves the pain, that helps us diagnose this as a gonadal neuralgia.
And then you can focus on treating the nerves to the testis.
Right. Yes. With either surgical intervention, spermatic cord denervation. Some people have proposed, and I actually do this, performing serial cord blocks with a very mild steroid with triamcinolone or Kenalog. And the idea here is based on great work by Dr. Sijo Parakatel, and that is looking at patients with chronic scrotal pain. And those patients who had surgery for chronic scrotal pain actually had tissue biopsied and sent to a pathologist. And they were identified to have chronic neuropathies, evidence of chronic neuropathy with something called Wallerian degeneration. And I explain to patients that what that is essentially kind of a nerve that's in chronic repair mode that hasn't been capable of like fully getting through the repair mechanisms, and that nerve has become inflamed. And those are signs based on chronic pain literature that suggest the origins for neuralgia in some chronic pain conditions. So those studies that found those patients are kind of the support behind the prior existing data that says a spermatic cord denervation can be very effective for people with idiopathic orcalgia. So spermatic cord denervation is very similar to the varicocele surgery, where you're going to the spermatic cord and essentially stripping the non-essential tissues. You can leave behind the spermatic artery, lymphatics, and the vas deferens, but going after some key components like there's a posterior fibrofatty bundle of the spermatic cord. There are perivasal nerve bundles along the vasculature, and then the cremasteric bundles have a high density of these neurons that have been found to have degeneration on them.
Great.
So I think a really important point to make about approaching chronic pelvic pain is, Dane, do you expect every urologist listening to this podcast to do that?
No.
Right. So one really important concept is to get patients to the correct place. I see a lot of patients who, again, I mean, like the brain and the nerves process all pain in our body, right? Whether it's organ-based visceral pain or whether it's, more somatic pain. I see a lot of patients who have, since I'm avoiding dysfunction expert and a neurourologist, who have avoiding dysfunction. And so we see all the patients who have chronic autonomic syndromes. It may impact bowel and bladder, and they also have these chronic overlapping pain syndromes. So many of those patients end up having something called small fiber neuropathy. Do we expect a urologist to take care of the specifics of nerve pain to the testis, or the specifics of a peripheral neuropathy called small fiber neuropathy? No. So we'll refer them to the right place within urology or across fields. So the important concept is just to recognize where the patient should go and to get them there. I mean, most of us in our communities have someone who has an expertise beyond ours who might be able to help a patient with these issues, whether it's neurosurgery, if the patient experiences acute pelvic pain after lifting something too hard, or whether it's one of these more diffuse neuropathies, recognize that the patient has a true issue and sort of directing them to the correct place.
Absolutely. Yeah, that's a great point. And I think it was something that you brought up at the beginning of the question, which was, how do you direct for these specific patients their care to a specific modality? And the honest truth is, I kind of use them all. Many times patients come in with more than just one symptom of this testicle hurts and nothing else hurts. It's great when they do, and I can kind of focus on one problem, but many of them have kind of the multi syndromes of bladder, bowel, or ejaculation. And so as soon as I hear a symptom, I am kind of pivoting in my mind. I'm also going to include potentially a physical therapy referral. I'm also going to include some of the pharmaceuticals that are directed at bladder emptying or pelvic pain. I'm going to include my partners who specialize in bladder emptying if there's a suggestion of a pathology there as well.
Mm-hmm. Yes. And also, of course, there's psychology, right? So I think most of us are pretty trauma informed in our patient approach. When you're going to do a physical exam, is there anything that makes you more comfortable during the exam? That gives the patient the open space to establish control and maybe disclose a trauma history if they find it relevant. And then when we refer to psychology, I think most urologists are pretty good at couching it as, psychology can help you with your pain, that there are good randomized controlled trials showing that we can use the brain to control the pain. This physical issue is difficult to work through, and the pain psychologists really know how to give you those strategies. So when I refer to psychology, it's usually a very positive thing for the patient. But one of the things the guideline recommends is not referring to psychology without an appropriate medical workup.
Great. Let's flip the script now. Want to get both of your thoughts briefly, since we're running out of time. What are the biggest mistakes you see in managing these patients? And what should clinicians avoid when treating patients?
I would say, if somebody has pelvic pain and you do a cystoscopy and the cystoscopy is negative, that should not be the end of the road. Like, hey guy, looks great. Glad to give you good news. Call me if you have any problems. The patient still has pain, right? So just that extra ounce of creativity and trying to get them to the right place is really life or death for these patients.
Yeah, and actually, I want to hone in on the second part that you said is getting them to the right place. I think one of the biggest shortcomings of kind of a lot of the patient's experience is that they get left kind of feeling like there isn't help. And so if there's anything to take away from a lot of our conversations, it's that there are specialists that are motivated, that we can get people referred to the right place, but the referral has to happen. It can't just be, well, we've done the cysto, we got a scrotum ultrasound, there's no pathological urological issue, so we're going to end the conversation there. It really needs to be, well, we've ruled out the really bad things, but we're going to need a specialist help here, so we're going to get you to the right people.
And there are a lot of self-help resources out there for patients. So I've tried to put everything I could on facingpelvicpain.org for patients to self-help, and then the patients can help the clinician figure out what the right next step is just by reading on their own as well, or watching videos.
Okay, thank you. So we've covered a lot of ground, but before we wrap up, I'd love to hear your top take-home points. What's the one or two things you wish more urologists did in clinic?
I think when it comes to this patient population, I'd like for a urologist to treat the pain symptom as much as a physical finding as it is as a patient's history. Specifics of when it hurts, how it hurts, why it hurts, bad does it hurt, can go a long way for making the diagnosis of how we can help these patients. And so, sometimes that starting that conversation, even if you're not the expert that ultimately performs some of the more complicated or nuanced interventions, I think having a thorough pain history helps a lot for patients' understanding of their problem and working that much closer to a diagnosis.
And for me, just pre-documentation of the patient so that the time is more efficient, getting a good history, and when the patient gives you a clue, hearing that, for example, if the patient has pain when they're standing up, that means something, and following that to the next step. Oh,
Right.
another point is what I would love for all urologists to do is when the patient has chronic pelvic pain, not to stop being a urologist, hear the rest of it, consider there could be a kidney stone or bladder outlet obstruction, note the hematuria, look for the appropriate cultures, and because the pain can be really distracting, especially if the patient's anxious or angry.
Great. Well, Dr. Day, Dr. Johnson, thank you for sharing your insight and for your contributions to the new AUA guideline on male chronic pelvic pain. Chronic pelvic pain is one of the most complex conditions in urology, but with the new AUA guidelines and multidisciplinary mindset, we finally have a framework that's both scientific and compassionate. This guideline represents a significant advancement in understanding and managing a condition that affects countless men, yet too often goes untreated. To explore the full document, supporting tables, and CME modules, visit AUA University at auanet.org/university. I'm Dr. Mark Gonzalgo. Thank you for joining us. And as always, stay curious, stay compassionate, and keep advancing the art of urology.